Good morning, Bob Ravenscroft, Vice President for Advancement, here for our September 29th, 2020 press briefing. We have a special guest here with us today that we've been telling you about. We have the team cardiologist for the world-famous Nebraska Cornhuskers, Mathue Baker. A while back, we had Dr. Stoiter on to talk about when myocarditis was early coming into the news. It's essentially everything Dr. Baker will talk about, but I want to share one thing we measure here is quality and satisfaction. We do it with our physicians, with our employees, with our past patients, and one question that is asked is, what would you do or would you recommend this physician or this facility to a member of your family? And Dr. Baker fits that mold. I have someone very dear to me who's a college athlete who had some cardiac issues. We entrusted her to his care, and I would absolutely recommend him, as clearly the University of Nebraska does. So he will be talking about a cardiac testing that is happening for the Cornhuskers and some of the other area schools. Very talented physician. Did his medical training at the University of Nebraska Med Center College, did his residency there as well as his fellowship. He is board certified fellow with the American College of Cardiology and American Board of Internal Medicine. So honored to have him here today, and we'll bring him up after the daily reading of the stats. We did have 6 advanced questions we'll get to after Dr. Baker's presentation. Right now, we have administered 24,511 COVID tests. Our positives through those tests are 2,839. Right now, we have 52 positive COVID patients in Bryan Medical Center. 37 are from Lancaster County and 15 are from outside of Lancaster County. There are 3 additional patients, all Lancaster County patients, that we're awaiting the results of their test. Of those, we have 9 patients on ventilators. 5 of them are from Lancaster County. Of these inpatients, 20 are in the ICU, 7 are in progressive care, and 25 in general care.
I'm just going to start with a little background. It's probably about 8-9 years ago when I first came here. There was a niche need for physicians to care for athletes, and when athletes are exerting themselves at extreme levels, elite levels, that's a lot of stress on the cardiovascular system. When we first started doing that, there wasn't a whole lot of other people doing that, and since that time, over the past 7 to 8 years, the organizations have really kind of come together, and we actually have a subsection within the ACC, and we have a lot more information and organization about how to approach these things. I've had the pleasure of seeing athletes of all calibers over the last 8 years, from professional athletes all the way down to high school, and of course our weekend warriors. We see a lot of those guys as well. So it's really been one of the more enjoyable parts of my practice. I appreciate that a lot. I've also had the pleasure, more pertinent to today, to being the team cardiologist for the Nebraska Cornhuskers. As many know, Lonnie Albers has been the team physician there for a long time, and I've developed a really great relationship with him. He does such a nice job there, with the athletes, and so they're just absolutely great to work with. And there's been a lot of really preparation and work that's went into that over the past really 3 to 4 weeks. I'm sure everybody in Nebraska remembers, right about when the season got canceled, there was some concern with something called myocarditis. And myocarditis is just a very general term for inflammation of heart muscle tissue. There was a lot out there in the social media realms about what was going on then, but there was some concern on some MRIs that were done at one of the Big Ten universities, and at a high enough rate that the season was delayed. And we have a subcommittee of Big Ten cardiologist representatives from every institution in the conference. And we all get together on Zoom meetings. We just had another one for 2 hours last night, and worked through the channels, and we're able to come up with a plan that we feel we can get athletes back on the football field safely. And that's what we're currently working through right now. Fortunately, here at Bryan, we have lots and lots of resources and technology at the highest level. So everything the Big Ten is asking us to do, we're going to be able to do, and we're going to be able to do it quickly to make sure that these guys are not just getting on the field, but getting on the field safely, efficiently, and quickly. One of the unique challenges in dealing with athletes is, especially in season, everything is done with urgency. Getting them on the field every day of prep is a very big thing for the coaches and for the athletes themselves. We're fortunate enough here to have those kind of resources and commitment, from the top on down. We have technicians working extra days to get everybody the testing that they need done. And we're going to do whatever it takes to make sure things are moving smoothly. And it's not always the case everywhere else. So we're very, very fortunate to have that tight relationship with the University of Nebraska and have the support that we have here at the hospital, as well as the technology. So this is essentially what tools the Big Ten is asking us to use in our athletes, and I'm taking those tools and applying them to other college athletes and high school athletes that we're seeing from around the community. For everybody who has a previous diagnosis of COVID dating back to when we first started testing athletes, we are getting lab work including a high sensitivity troponin. Troponin is a protein that's made only in heart muscle tissue, so when we see it in the bloodstream, we know where it's coming from. In general, it's considered a very sensitive marker, so any sort of stress or damage going on in the heart, you'll see those numbers start to go up. With myocarditis, they tend to stay up a little longer than some of the other things that we check that blood test for. So we think that's something valuable. That's something we're doing in everybody. Secondly, everybody's getting a plain EKG, a very simple test. Fortunately, at Nebraska, all the athletes that come in have a baseline EKG, which is very helpful so we can compare what things look like to what things looked like when they came previously. It's the changes that are most valuable with that. The last thing that we're doing in absolutely every athlete that was diagnosed with COVID is an echocardiogram, which is basically a fancy ultrasound of the heart. We have, again, some very nice technology in our portable ultrasound machines, so we can check for some different things that we'd like to make sure we're getting in all of our athletes, such as strain, which is kind of a precursor or an earlier sign of any stress or damage to heart muscle tissue. So we're gathering information on all of these athletes. One of the things that the Big Ten has asked us to do as a group of cardiologists is to start a registry. And we have a very large number of athletes that have been diagnosed with COVID, and trying to pool all of our data together so we can make sense of it. The more numbers we have, the more valuable those numbers become in making sure, that we're doing what's right for everybody. But that's a lot of the heavy lifting that's going on right now. There's a lot of very experienced cardiologists. Some of the biggest names in cardiology are in the Big Ten and are on this committee. And last night, somebody who's been dealing with the Big Ten cardiac issues for, I think he said 30 years, Larry Rink, said that this is the biggest endeavor that he's ever undertaken within the Big Ten. So this is something that's being taken seriously, and everybody is funneling resources to this and making sure that we get things going on track. Had the pleasure of seeing right around 200 athletes over the past 3 to 4 weeks as this information and concern for myocarditis has spread. And we definitely appreciate their support. We're in constant communication with team physicians and with trainers who are tasked with taking care of all of these athletes and making sure everybody is safe to return to play.
Certainly not all of them are older, but most of them are, and most do have comorbidities of one form or another. The most common ones are diabetes, hypertension, and obesity. Today's age range of inpatients related to COVID-19 is from 37 to 96. And then just some further age breakdown in September, about 4% of our patients have been between the ages of 10 and 29. It jumps up to 5% when you go up to the age of 39. Add in another, it goes up to 15%, 49 and younger, and then about 40% are 59 and younger. Specific to September, there absolutely has been a jump in older patients in this month in the 70-79 age range. 29.59% are from that age range, and 15% are 80 to 89, and 8% are older than 89. Those are the significant jumps from the previous months. For instance, those 89 and older used to be about 4% of the patients. Those 80 to 89 were also 4%, and 70 to 79 was previously only at 17%. So yeah, definitely a climb in age, but again, not all of them are older. Our total ICU capacity is about 89 beds, and then we have many, many more that are set up for negative air pressure rooms that are vent capable. So as far as overflow beds for the ICU set up in the early days of the pandemic, the short answer is yes, we've used these. But I do want to stress that this bed management is something that occurs, on a daily basis here, and it's not all for COVID patients. It's a daily function of our chief nursing officer and nursing leadership. And what we're facing now is kind of indicative to the peak flu season, or what we were experiencing kind of from November to March last year. You're always kind of doing this daily jigsaw puzzle of putting, daily discharges, admissions, and services needed. Now, the monkey wrench that COVID throws into this is the length of stay. These patients occupy our ICU beds for longer than other patients typically do, consume more resources, and general care beds also much longer. Currently, we have a handful of patients from a senior care facility. This kind of is indicative of the challenge. They are better. They've tested negative now through the course of their treatment, and there's no reason to be hospitalized, but they are not 21 days out, so the senior care facility won't accept them back into their homes. So along with our staffing concerns we talked about in the last briefing, some of the most distressing things that we're dealing with is kind of the impending, what I'd call twindemic of COVID and flu, and getting these patients back into their homes when they can be cleared will help clear some of that up. There are patients that get ill very rapidly. However, the majority of them are diagnosed earlier. They quarantine, and as the question said, they attempt to ride it out and watch their symptoms and then deteriorate. This seems to occur about 1 week post-testing positive, or 1 week post the onset of initial symptoms. So when that community spread happens out there in the community, and it goes into some of the higher risk populations, it's about 1 week out from their symptoms to when they can't ride it out at home any longer.